We thought we'd start off with an easy question for you. Hopefully it's easy. A 62-year-old man with a history of ST elevation myocardial infarction and ischemic cardiomyopathy presents for a follow-up visit. Ejection fraction 1 year ago was 25%. After 1 year of treatment with guideline-directed medical therapy, and we like to use GDMT, ejection fraction has increased to 40%. Which of the following terms is most appropriate to describe his heart failure? A, heart failure with preserved ejection fraction. B, heart failure with reduced ejection fraction. C, heart failure with mid-range ejection fraction. And D, heart failure with improved ejection fraction. Now please participate. Nobody knows who's answering what, so we'd like everybody to participate. The only few I'm tracking are my office staff.
So for those of you coming in late, if you just scan that QR code, it will bring up the answer choices on your phone. The entirety of the question is in your packet. There's just a summary up there, and then you can answer using your phone.
Okay. So about 60% said heart failure with improved ejection fraction, which is the correct answer. Rich, you have...
Yeah, let me just comment about where these terms come from. So if you, when you order a serum sodium or any other blood test, right, there's a bell-shaped curve of normal, and they declare 5% of everybody being abnormal. That's where those ranges come from. But that isn't actually where the ranges come from for ejection fraction. And that's a sort of a mistake of history. So where does the term reduced ejection fraction come from? It actually came from many years ago when we designed the first clinical trials on heart failure. We tried to say, let's pick people who are sick enough that we may be able to show impact in a reasonable length of time, you know, like 1, 2, 3 years. So we just picked 40% as a number only because those were sicker people. 40% is actually not anywhere near what a statistician would choose to define low ejection fraction. So in the normal population, men have a lower ejection fraction than women. And that's a very simple reason. It's because men have bigger hearts. And so it doesn't take as much ejection fraction for a volume of a heart that's bigger to maintain cardiac output. So lower limit of normal for a man is 52%, and for a woman it's about 56%. So in theory, anybody below that should be labeled low ejection fraction heart failure. Okay? But we don't do that only because the clinical trials chose 40%. So in common parlance for many years, 40% and less was called low, and above 40 was called preserved, which is totally stupid because 41 is still low, right? And that's where then the term came, mid-range ejection fraction. It's a continuum, but in theory, anybody below 52 should be called low ejection fraction heart failure. Now, in this particular case, fortunately, the person had a beneficial response, but only what I would call a partial response. Wouldn't we love to have somebody have an EF back in the normal range in the 50s or 60s? Sure. If you put somebody like this person, ischemic dilated cardiomyopathy, comes to me fresh, no meds, the most important medicine to increase ejection fraction in this patient would be a beta blocker, and the average EF goes up 9 percentage points on a beta blocker. The other guideline-directed medical therapies that were just mentioned, each increase ejection fraction about 2 points, right? So if you put somebody on sacubitril valsartan, which is Entresto, plus a beta blocker, plus spironolactone, plus now an SGLT2 inhibitor, you'd expect the average person to go up about 13 to 15 percentage points. And that's what this person did, right? They went from 25 to 40. Now, would we love 60? Sure. Is that realistic? It comes sometimes as achievable. The problem is, what do we do with somebody who is a partial responder, like this person? They're still 40. That's still a low ejection fraction. So either answer would be, to me, accurate. Is it improved? Sure. Do they still have a low ejection fraction? Yes. Nobody here would prefer to have an EF of 40%. Right? So it's better. It's not better enough. This might be somebody where additional therapies would be helpful. You heard about preserved ejection fraction heart failure. now with GLP-1 receptor agonists, so that might be something we consider. This would be a patient maybe he would consider a defibrillator in, those types of things, cardiac resynchronization therapy if there was bundle branch block. So we have actually more tools to help this patient. But even though Mo said this is a simple question, it's actually more complicated than we would think, you know.
So, we'd like to start patients on quadruple therapy. But if a patient has a reduced ejection fraction and tells me they're very reluctant, they want to start only one and we'll go from there.
In a patient like this, the most important are beta blockers. Not true the higher the ejection fraction is, but for sure in a patient like this, and it's not, and it's heart rate dependent, and some people need higher doses of beta blockers than you may normally be used to using, right? So in the original beta blocker trials, that was called the MERIT trial, metoprolol succinate was used over 4,000 patients. The average dose achieved for a man was 159 milligrams per day in that clinical trial, okay? So we have to go to higher doses. The instructions in that trial was that if the resting heart rate was above 60, we boosted the dose. Now, the importance about that is the number 60. Because most of you, if you put somebody on 50 milligrams of metoprolol succinate, they come to the office and their heart rate's 66, you'd probably say, great. Except in the clinical trial, that person would have then gone to 100 milligrams. And the next time they came in, they go to 200 milligrams. And I have people on 400 milligrams. Because it turns out that if you then stratify by the achieved heart rate, and by the way, the heart rate in that clinical trial was defined on an EKG, not on when the person first comes in, sits down, and your MA takes their heart rate and their blood pressure, because their heart rate's still fast from having walked. So they lay down, they get the EKG patches put on, and that's important because the heart rate actually declines during that period of time. And if their heart rate's 60, they're perfect, right? And if you don't believe me, look at a trial that used a different drug added on, in which a heart rate of 74 at rest versus 70, there was a 20% decline in mortality going from 74 to 70 on a resting. So it's really important that the heart rate go down. We are not sure to this day why that benefit is so manifest, but for ischemic dilated cardiomyopathy, it's important to get a heart rate of 60-ish. You know, I'm not going to quibble if it's 62, but it shouldn't be 75. You need to push the dose up.
Okay, question number 2. Note to myself, where they printed these questions, you can't see the question number. Should be at the bottom of the page, I guess. Okay, a 61-year-old male with a past medical history of obesity, type 2 diabetes, hypertension, and heart failure with a preserved ejection fraction, HFpEF, presents for follow-up visit. He states he has lost 25 pounds in the last 3 months with an improved diet, and his BMI has dropped from 36 to 31. His blood pressure is 120/70. Physical examination is unremarkable. He's on metformin and losartan. Clothalidone was discontinued because he was diagnosed with gout. Which of the following medication recommendation would reduce the patient's number of hospitalizations and cardiovascular risk? Some Jeopardy music. Okay, great. So 85% says DAPA, and I'm glad to see 0% said DIG. 0%. So,
well, yeah, DIG is having a resurgence, but not for this patient, right? Digoxin is useful. It's a whole separate talk you've heard probably, but it's useful for reduced EF, not for preserved EF. And as you heard earlier today, preserved, in this particular type situation, this is really viewed as obesity of the heart. So 80% of people with classic preserved ejection fraction heart failure have obesity, right? As this gentleman still, even though he lost 25 pounds, he's still obese, right? And so the right answer here would be, I would agree, an SGLT2 inhibitor. It doesn't have to be dapagliflozin. There are half a dozen of them, and you heard about earlier. It can be sotagliflozin, dapagliflozin, empagliflozin, erdagliflozin. There are a bunch of them. And as best we can tell, they all work. So an SGLT2 inhibitor for sure. But I would also really be tempted to put this guy on a GLP-1 receptor agonist because the HFpEF data are really sound with that. It would offer the benefit of lowering his weight to a greater degree than an SGLT2 inhibitor would. It would allow him to get off metformin. And remember, in metformin, there are no good data that it makes lives longer or better. All it does is treat a blood sugar. And so that would be something I think that would be advisable. And today, the best regimen for somebody like this would be a combination of a SGLT2 inhibitor and a GLP-1 receptor agonist.
So current treatment for heart failure with preserved ejection fraction versus reduced ejection fraction. What's the current guidelines?
So that what you heard earlier, guideline-directed medical therapy, the tetrad of therapy, the core four that we had mentioned, only applies to people with reduced ejection fraction. There is some argument about how high does it have to be before we no longer call it reduced, right? So let's just use the number 50. If it's below 50, I think everybody should be on those core four. If it's above 50, then the strongest data are with the SGLT2 inhibitors and the GLP-1 receptor agonists. There are middling data with spironolactone. There are no data for beta blockers. They lose their benefit the higher the ejection fraction. So unless somebody has another reason, and that reason can be they have an arresting tremor that you're putting them on propranolol, or maybe they have SVT and you're using a beta blocker for arrhythmia control. But for cardiac benefits, once your ejection fraction is in the 50s or higher, the beta blockers really don't help. And a drug like Entresto, sacubitril valsartan combination, is one of the few drugs where there's a gender difference. So if you have a woman whose EF is 55 and has heart failure, she benefits from that drug, men do not. So that's one of the few things where there's a gender difference in terms of our choice of treatments for heart failure.
So under 55% quadruple therapy?
Yes, or under 50 for sure. Once you get above 50, the closer you get to 60, the less the benefits are of the traditional medicines used for heart failure. Now, that isn't true of an SGLT2 inhibitor, right? They, across the board, until you get an EF above 70, and if you have a heart failure patient with an EF above 70, you need to look for other things, hypertrophic cardiomyopathy, other things. But if they have the heart failure syndrome, regardless of ejection fraction, an SGLT2 inhibitor helps, any of them. But the lower the ejection fraction, that's where the core four come in. The higher the ejection fraction, GLP-1 receptor agonists, and maybe spironolactone.
Now, I see quite a few patients who are doing well, compensated. They're on a low dose of Lasix, let's say 20 milligrams, no edema. And I often wonder, I'd like to discontinue the furosemide and increase the spironolactone. What's the maximum dose on spironolactone I can go? If renal function is stable, potassium's okay.
100 milligrams. I mean, in the heart failure world, normally we don't go to those doses, but you have patients for dermatologic reasons that are using 100 milligrams a day. You have women sometimes who use it because they don't like the hair on their arms, et cetera, et cetera. Those were the doses used in the old days when spironolactone was first developed. We tend to use 12.5 or 25, and there's a smattering of data that higher doses may be a little better, but I'd like to have everybody on 25 milligrams if they could. And the main stopping point is not hypotension. The main stopping point is hyperkalemia with the mineralocorticoid receptor antagonist.
Even the
And for
cirrhotic
sure-
population, you see higher doses in the cirrhotic population.
Yeah, and for sure, Mo, what you just said, a lot of people do not need loop diuretics. And there are a lot of downsides of loop diuretics, right? Hypokalemia, hypomagnesemia, and other things. So if somebody doesn't need it, and how do you know that? If they don't have neck distension, vein distension, and they don't have edema, they probably don't need a loop diuretic, honestly. And they're better off on a drug like spironolactone, which, although listed as a diuretic, in this case is not really being used as a diuretic, right? In heart failure, the mineralocorticoid receptor antagonists are used because they alter the natural history of the progression of heart failure. They're antifibrotic, they have anti-growth properties, and yes, they have antihypertensive, et cetera, but it appears to be a beneficial effect not due to diuresis per se. So on the choice in a person like this, preserved EF heart failure, would I rather have them on spironolactone or furosemide? If they're not volume overloaded, for sure spironolactone.
Okay, page 3, the next question. A 62-year-old male presents to the emergency room with increasing shortness of breath for 3 days. He has a history of hypertension, type 2 diabetes, coronary artery disease, and obesity. On examination, he's tachypnic, has bibasilar crackles on lung examination. Chest x-ray shows mild pulmonary congestion. Troponin is negative. BNP is normal. Which of the following explains the patient's normal BNP level? A, early stage heart failure before BNP elevation occurs. B, lab error in BNP measurement. C, high body mass index. D, non-cardiac cause of dyspnea. Okay. Right, 59% says early stage heart failure before BNP elevation occurs.
Well, the good news is that's absolutely the wrong answer. So, I mean, the other ones are possible, but that is not. So, BNP, and I would caution you, we don't, in heart failure, in the heart failure world, we don't use BNP anymore. We use NT-proBNP. The reason for that is, remember, the molecule's made as a pre-molecule, then it's sliced, and the BNP part is the biologically active part, but it's metabolized quickly and all sorts of stuff. The little tag piece, the NT-proBNP, hangs around longer, and it's a better marker, right? So in no heart failure trial that we're currently doing do we use BNP anymore. It was a great measurement 15 years ago. It's been superseded. Much like you can still diagnose an MI using CKMB, except why would you? We have troponin. We don't need CKMB anymore. So you should really look at NT-proBNP. Now that said, obese people, and the important words were obesity here, right? And his BMI is 35, so the person is pretty obese. They have a often misleadingly low level of BNP.
So the answer was C.
The answer is the high body mass index means because fat people metabolize the BNP differently, they will have artificially low levels of BNP. And in fact, if you look at the clinical trials, the GLP-1 receptor agonist trials are a great example. They enrolled a bunch of people with a clinical syndrome of HFpEF with obesity. And the average person in that trial, in a heart failure trial, had a normal BNP level. So the old data where BNP is you know, the predictive accuracy is great, et cetera, that's true for low ejection fraction heart failure, et cetera, or somebody presenting with acute dyspnea, kind of like this person. But a low BNP in a fat person does not exclude the diagnosis of heart failure at all. So that's by far. Now, could you say it's a lab error? I guess. I mean, they could have used the wrong tube, you know, or something, but probably not. Could it be a non-cardiac cause of dyspnea? I guess. Somebody could have more than one thing. You could have pulmonary fibrosis or something like that. So you can't exclude it from the data that I have here. But by far the most likely diagnosis is that it's an obese person with an artificially low BNP.
Dr. Wright, can you comment on trending the proBNP? So during the hospitalization as
Yeah,
an outpatient.
so, and there's controversy about this, and I'll put on my Medicare hat. I will tell you too many BNPs are ordered, and that's because if I'm actively adjusting medicines and somebody's NT-proBNP went from 4,000 to 3,500, does it affect me the next day? Probably not, right? So every single day, unlike the potassium, which can change quite dramatically, it's not going to influence me much. Now, that said, if you ended up hospitalizing this person, and I would suspect most people would end up being hospitalized. I can tell you in our clinic, if somebody presented in my office this way, we'd give them IV Lasix in the office and see him tomorrow. I wouldn't admit him. But unless he was hypoxic or something. But if he gets admitted, there are data that prior to discharge, if you haven't made an impact on the NT-proBNP, if it's 4,000 when he presents and it's still 4,000 3 days later, you probably need to intensify your therapy because the change, the direction, prognosis, how somebody's going to do in the coming weeks. And the hospital administrators go ballistic if you send somebody home and then a week later they get readmitted, right? Because then they get dinged by Medicare for readmission. So it's important to say, yes, we're making progress, and one way to say that isn't just you put out 2 liters of urine and your weight's down and your edema's better, but also the NT-proBNP. So I don't think you need daily. I think that just drives up the cost, but I think having another one is useful. What was that?
How soon after hospitalization?
Well, the half-life of these is very short, and one of the reasons, so before the BNP elevation occurs, it actually turns out that heart failure, typically when a person presents like this, they've had an issue for 2 to 3 weeks. And we know that because if you do prospective monitoring of invasive or other means, including NT-proBNP, things change for 2 to 3 weeks before the patient finally presents, which is why the answer that was chosen by 45% of the people is wrong. The BNP actually was going up a week or 2 before you even knew the person was getting into trouble. It will change on a daily basis because the half-life of these biomarkers is hours. In BNP, it could be shorter than that. So it's going to change rapidly, and I would change, the next time I would see the person, which would be within a week after hospital discharge, we would recheck the NT-proBNP.
So I suppose if a patient is doing well, hospitalization, you're contemplating discharge, you haven't checked it for 3 or 4 days, maybe.
I think it's reasonable to check it pre-discharge. I do, yeah.
If he's in the ER, this patient, what happens? Do you admit him or don't admit him?
Well, yeah. So, I mean, me being a heart failure doc and all I see is heart failure doc, do I think this person needs to be admitted? There's sometimes I do. Obviously, if the person is on BiPAP and pulmonary edema and their O2 sat is 86%, I mean, that person needs to come into the hospital. If they said, I've been having progressive edema, I'm more short of breath, but they're clinically stable, meaning their vital signs are stable, they're oxygenating well, do I actually think this person needs to come into the hospital? I do not. But the reason is because being in the hospital and babysitting the person, I mean, think about it. What do you do mostly when you have somebody in the hospital this way? You give them 1 shot or maybe 2 of IV Lasix, and then you just watch them. I mean, what are you actively doing in the hospital for this person? You know, nothing. So as I tell them, I don't need to babysit you in the hospital. Now, I will tell you that, again, the hospital administrators, if this is a very straightforward heart failure patient who I think is going to go home in 2 days, they would love me to admit the person because it costs them 2 shots of IV Lasix, you know, and they make the DRG. So do I think this person needs to come in the ED if they got a shot of intravenous furosemide, they diuresed 1.5 liters, they're feeling better? Do I think the person needs to come into the hospital? I do not, unless their vital signs or oxygenation are abnormal. But they need close follow-up, right? They can't say go home. And so we would see them literally the next day in our office if they get sent home from the emergency
You
department.
don't follow the NT-proBNP, right?
No. So, yeah, so the things we would follow would be, so the question is, what do you follow over the first? So for sure, and it depends on what the person's creatinine is, et cetera, but for sure, basic metabolic panel kind of things, right? And the potassium and the creatinine are the ones that influence what you and I would do. Am I going to increase spironolactone? Am I going to add a second diuretic to the loop diuretic if the person's not diuresing adequately? Older people, the serum sodium often is another one, right? Because a lot of these people come in with hyponatremia, and that will then influence our choice of medicines. But all those things are measurable as an outpatient. Now, it's true the turnaround time is faster, so in the ED, you're going to get the labs back pretty quickly. When I round on the person the next morning at 7 in the morning, I already have their labs, so there's expediency there and ease. But it could all be done as an outpatient. Now, if somebody lives, I don't know, in the furthest reaches of the northwest part of the state here, or northeast or something, live in Susanville, and I mean, there may be times when it's better just to say, listen, you're in a rural area, it's going to be hard for you to come in every day. Then that person, I think, should come in. So there's social issues. If somebody, you heard this earlier, if they're a methamphetamine addict and they come in with decompensated heart failure, and they're not going to take their medicines unless they're in the hospital, that may not be another reason. So there are other things we need to, you know, decide on.
Just to be sure, the pro molecule is not affected by the BMI?
So the question is the NT-pro, it is
It is.
partially, the NT-proBNP, which is, as I call it, the tag piece, it's a non-biologically active. But remember, most hormones are produced as precursors, and then an enzyme slices it, and then the active moiety is what goes around to receptors and things like that. And usually the tag piece, which is not biologically active, hangs around longer and has different receptors. Is it influenced by obesity? To a much lesser degree than BNP, which is why it's a superior marker. And also it's like, think of the hemoglobin A1C. I mean, you know, your glucose can go up and go down, but the hemoglobin A1C integrates it. And the NT-proBNP integrates over a longer period of time, which is why it's a preferred marker.
Okay, next question. A 29-year-old woman with a past history of heart failure, diagnosed 1 week after birth of her first child 2 years ago. LV ejection fraction was 25% at the time. She has been taking daily furosemide, potassium, carvedilol, and quinapril since that time. Her echocardiogram 2 months ago showed an improved left ventricular ejection fraction of 40%. She comes in accompanied by her husband contemplating another pregnancy and was referred by the obstetrician for your opinion. She has no current symptoms, physically active, and walks 45 minutes on the treadmill 3 to 4 days a week. Which of the following is the most appropriate recommendation? A, advise against pregnancy. B, discontinue quinapril and continue carvedilol. C, discontinue carvedilol and quinapril. D, discontinue all meds since she's asymptomatic. Okay. 67% say discontinue ACE inhibitor.
Yeah, not the answer I would have chosen. So let's talk about what this lady has. So, you know, the way it lays out, she probably has peripartum cardiomyopathy, right? An unusual complication of pregnancy, either at the very end of pregnancy or soon after delivery. If you genotype those women, many of them actually have a genetic propensity for a non-ischemic dilated, or what we used to call idiopathic dilated cardiomyopathy. But some of them have no explanation for why they had the heart failure state appear near the time of delivery. Now, if you follow those people clinically, half of them or so normalize. At least they normalize by ejection fraction. Even without treatment, many of them normalize. So the EF would be 65 or something instead of 25. But the other half have some residual dysfunction. And a 40% ejection fraction in a woman who's 29 years old is egregiously low, right? So this woman either has genetic dilated cardiomyopathy that happened to manifest during pregnancy, or she had peripartum cardiomyopathy that didn't get better, because 25 to 40 is not getting better. In such people, if they get pregnant again, they have a very high likelihood, a more than 50% chance, that they will have overt worsening of their cardiac function during that second pregnancy. In fact, they could die from heart failure. So it is most commonly the case that if somebody has residual dysfunction, that you would strongly consider not getting pregnant again, just because of the risk to the mother of having profound heart failure. So I do think that the appropriate answer here would be to advise avoiding pregnancy, and particularly because most of the heart failure meds are either not safe or not tested during pregnancy. So what you don't want to do is allow somebody to get pregnant, and then you have to potentially withdraw some of the medicines, and now their EF may go down to 20%. And I can tell you, having had 3 women die in CCU delivering their baby, and they died, and I had an orphaned infant because they had end-stage heart failure. This is not something you want to fool with. I would tell you, though, that the lady's on inadequate medicine. So discontinuing medicines would be the wrong thing. Now, you could say discontinue quinapril and instead put her on sacubitril valsartan. Okay, I get that. Entresto's better than an ACE inhibitor for something like that. But you certainly want to advise avoiding pregnancy and honestly put her on more medicines. It doesn't matter whether somebody is clinically asymptomatic. If their EF is 40%, they will do better on long-term medicines.
So a couple of follow-ups. One, like you're saying, I think she needs to be on better therapy, so we advise also against birth control methods because you are going to put her on medicines. And then two, what if her EF did recover to 65%?
Yeah.
Is it a different conversation?
Yeah, so let's say that it recovered, she's 65, feels like $1 million, okay, and is on no medicines, and there are women like that. So we tell them, listen, there's a 50-50 chance you're gonna have the same problem occur, and that's where the informed decision really has to come from the patient. Some of them, if it's only 50-50, they may be willing to say, we really want a second kid, we're willing to do that. But they have to be advised that it could come back, and it could be worse than the first time around. And certainly an EF of 25% is nothing to scoff at, you know. Have there been people like this who went from 25 to 60 who had a second kid and didn't have? Of course, there have been. So that's possible. And as to your allusion here about, because uniformly in 100% of the heart failure trials in young people, they had to be on birth control, so we don't have any controlled trials of what do you do who somebody's in their first trimester and their EF, what do you do? And you know, there are no medicines that have been tested in that scenario, so it's sort of you're on your own.
And if a patient, I have a patient, I mean, she comes in every year and, you know, her ejection fraction's around 55%. She's on optimal therapy. The same conversation. I want to cut back on my meds. I want to reduce my meds.
Yeah, I think that's a mistake. So in people who, maybe not peripartum cardiomyopathy, which is a little bit of an oddball, but if you just take normal, low ejection fraction heart failure patients who improve and are feeling great on medicines, if you stop the medicines, and the single most important one is the carvedilol in this case, half of them will have overt heart failure reappear as soon as they go off their medicines. So again, okay, you want to go off them, but I'm just telling you half the time your heart failure is going to come back. And it'll come back often in 2 weeks. I mean, it's not like 27 years later. We're talking right away.
What if this patient is already pregnant? How do you manage it?
Yeah. So, I mean, in that situation, so if somebody comes in having had heart failure or has heart failure and is pregnant, then obviously, if it's early in the pregnancy, do you talk about termination? Most of these can go through pregnancy. The ones that have big problems are like congenital heart disease with horrible abnormal plumbing and valves that are bad and all sorts of stuff. In the third world, most of it, like horrible mitral stenosis, for example, that's not a good thing with the hemodynamic changes that occur with pregnancy. But I think you're going to just have to do your best, if you will. And as I said, part of the problem is that none of these medicines, especially in the first trimester, I mean, I'll leave people on beta blockers the whole time. I don't care so much about bradycardia at the time of delivery in the fetus or something. But the other ones may interfere with normal, you know, like certainly ACE inhibitors are contraindicated in pregnancy. So if somebody is known to be that, they can't really be on renin-angiotensin modulators. I don't know about SGLT2. Do you have any knowledge about SGLT2 inhibitors? Embryo, I mean, yeah, but I don't know if they've actually been tested. That's what I'm saying. I don't know.
We can see if Corey was still around. He's our SGLT2 rep.
Yeah, I mean, I think I would leave somebody on beta blockers for sure, and then keep your fingers crossed.
What about digoxin? I'm just curious. Is that pregnancy?
It has been, again, you know, would I use it? I think it would be relatively safe. Now, the more recent data on digoxin is sodium potassium ATPase, the enzyme that digoxin blocks, is uniformly through other areas. And so it actually interferes with the immune system and other functions. It's not just heart and inotropy. So again, I would be a little cautious. I think the safest are the beta blockers. Yeah, so this is tirzepatide, and it says weigh the risk and benefits during pregnancy. Well, that's helpful. I mean, it's like if you don't know the risk and benefit, yeah, it just says weigh it. Yeah, it says
Just so we know, A was the correct answer for this question. So.
yeah.
Thank you. So, digoxin, you say it's resurfacing in heart failure with reduced ejection fraction.
Yeah.
When do you use it, and what's a dig level you would like it to be at?
Yeah, so the reason it's resurfacing is because there were actually old data that were kind of glossed over, if you will, that it actually did better than. So the original DIDGE trial, which was a huge trial in an era before we had the current core 4 therapies, and it's a very pure trial because it took a bunch of people with low EF, and the only thing they were on was either digoxin or no digoxin, because there was no ACE inhibitor, there was nothing else. And in that trial, the reason digoxin was poo-pooed is because they said, well, people didn't live longer, which was true. The mortality curves overlapped, placebo versus digoxin. Except if you go deeper into the data, A, they felt better, performed better, stayed out of the hospital, didn't get admitted with decompensated heart failure, and very importantly, the people that had low DIG levels, everybody got the same DIG dose. Turned out if you had a low DIG level, you had a mortality benefit. But people that had a high DIG level actually had an excess mortality. And they just turned out by happenstance that those were counterbalanced each other. So the interpretation of the data should be digoxin's helpful, but at about half the dose we used to use. So instead of 0.25, the average dose in a normal person would be 0.125, and then in somebody with renal dysfunction, it would be half of that, so either 0.125 every other day or 0.0625. And to answer your question about DIG levels, the trough DIG level in that clinical trial, if your DIG level was 0.8 or less, you did better. At 1, it was neutral. Above 1.2, you did worse, especially in women. So we want lower DIG levels, because when we trained, a DIG level of 1 to 1.5 was considered therapeutic. Now we know it's toxic. So low levels, but it's still a good drug for reduced EF heart failure.
All right, next question. A 20-year-old man comes to the office for a sports physical. The patient has played varsity basketball since high school. He's completely asymptomatic. Physical examination reveals a hyperdynamic apical impulse, a normal S1 and S2, and an S4 is heard. He has a 2/6 systolic murmur that increases with Valsalva maneuver. Echocardiogram reveals an interventricular septal thickness of 1.8 centimeters. Normal is 1.1. Ejection fraction 75%. At rest, there is no left ventricular outflow gradient. However, Valsalva generates a gradient of 30 millimeters of mercury. Which of the following is the most appropriate recommendation for this patient? A, alcohol septal ablation. B, avoid high-intensity physical activity. C, implantable cardioverter defibrillator. And D, metoprolol. Just trying to have a variety of questions for everybody in the audience, and some that we see. This was a patient that came to the office. Okay.
Mo, this is another one of those questions where I'm glad this wasn't on the boards because, so first of all, a 20-year-old athletic guy, and clearly they shouldn't have a murmur. He does, and his murmur, he has an echo that's consistent with hypertrophic cardiomyopathy, and that's clearly his diagnosis, right? So now what to do next is much more controversial. So the reason this is relevant is that hypertrophic cardiomyopathy is an advantageous genetic mutation for sports people, which is why if you look at studies of, say, the football team in 20-year-olds versus the chess team, okay, there are a lot more hypertrophs on the football team than on the chess team. And that's because when you have a thick heart, it actually makes it better for you to do certain sports, right? Like particularly football. Basketball, I would have thought, when I first read the first line, I thought the person was going to have Marfan syndrome or aortic dilation, ascending aortic aneurysm or something like that. But if it were a football player, it would have just been hypertrophic cardiomyopathy for sure. So it's an advantageous for sports, but disadvantageous for the patient because it's associated with eventually with heart failure and potentially with arrhythmias in this age group. And the older folks that have hypertrophic cardiomyopathy, it's not so arrhythmogenic, but it could be in this particular person. Now, even though B is the one chosen by most of you, what I would say is I don't have enough data with the data that's presented to know that, and this is a very common problem in the NFL Combine that just occurred, for example, where there's a higher incidence, and what do? So if you look at most recent data with like 1,000 athletes, it turns out that if you stress test these people and they don't have proarrhythmias, et cetera, it's safe for them. So right now, if you go to the centers that deal with the NFL and deal with soccer players and these people, they don't actually prevent them from exercising.
Even with a thick heart.
Correct. With the exception if they're having arrhythmia, and particularly if they're having arrhythmia that's provocable with exercise. So Matt Martinez, who runs this program back east, has published literally 1,000 athletes, and it turns out that it's safe for them to do exercise. Now, the other choices, so alcohol septal ablation sort of had its day, but has been superseded and no longer, in my opinion, should be done. Because if you're going to do any procedure on these people, and I'll get to that point in a minute, it would be surgery rather than giving the person an MI, giving alcohol into one of their arteries, which is what alcohol septal ablation is. So if you're going to do anything procedurally, it would be actually a surgeon removing excess septal tissue. But these days, the treatment for this would be mavacamten, which is, the brand name is Camzyos, and that's a myosin inhibitor that tones down the heart. So the guy has an EF of 75%. Nobody in this room has an EF of 75% right now. And that's because this particular person has a mutation where the heart is hypercontractile 100,000 times a day, every day of the year, and that leads to thickening of the heart and an ejection fraction to 75. And that is changeable and reversible using myosin inhibitor. So the best answer would be an oral myosin inhibitor therapy. And this person qualifies because he has a 30 millimeter gradient, right, which is what the minimum is for most insurance companies to pay for that particular drug. So my answer would be, in him, get more data, okay? More data meaning I'd Holter monitor the guy, right? Because if he's having VT, that's a bad sign. I'd actually, even though we do way fewer stress tests, because you heard earlier today that provocable testing isn't that helpful for coronary disease, but in a person like this, who's an athlete, who's got structural heart disease, putting the person on treadmill is actually helpful. Because if you did that and he went into VT, your answer is going to be totally different than if he didn't, right? Metoprolol may or may not be. I'm not a big believer in metoprolol. The beta blockers were first used in 1964 for hypertrophic cardiomyopathy, but the randomized trials do not show improvement in outcomes for people that are put on that. So I think the right thing to do is Holter monitoring, stress testing, and consider mavacamten to make a decision about whether to advise him that he can't play sports. And the last time I had an NBA player with this, okay, I told, because that person did have VT, and that particular person, when I said you shouldn't do sports, you know what his answer was to me? That's a $17 million per year decision you're making for me.
Wow.
That was his answer to me, yeah. He didn't care about his health, he cared about money.
Now, rarely, but occasionally, you see somebody with a very thick heart, let's say 30 millimeters. What would you do with that patient?
Make sure their will is, no. That again would be somebody. So depending on where the 30 millimeter thick heart is, right? So 18 millimeters is like 5 standard deviations are normal. This is really consequential because for a woman, the average thickness is 8 to 10 millimeters. For a man, it's 10 to 12 millimeters. So 18 millimeters is basically twice as thick. 3 centimeters, 30 millimeters, is huge, right? And that crowds the ventricle and causes havoc. So if it's in the septum and nowhere else, some people might argue that surgical septal reduction therapy would be useful. We genotype all these people mainly for genetic counseling purposes because it doesn't make a difference in our therapy currently. But for a 20-year-old with this disease, there's about an 80% chance that on routine genotyping, we would find the mutation that's causing this. And then you can look at siblings and parents and children and things as cascade testing, which I think is useful. But if it's that thick, then they have a higher incidence of lethal arrhythmias, heart failure, and then you would pull out more stops, including and sometimes depending. So the one way to stratify is getting a cardiac MRI, because if these people have a 3-centimeter thick septum and 20% of their heart's already scarred, which you can tell on an MRI, that person's a high enough risk that we would put in a prophylactic defibrillator in those people.
And we're starting to diagnose a lot older hypertrophics. Do you have a cutoff in terms
Yeah,
of?
so that's a very important point. So I currently have about 100 people on mavacamten in my thick heart program. The average age is 84. And it used to be thought this was a young person's disease. It is not. The genetic variety is a young person's disease. But there is a variant, the older variant, in which when you genotype them, usually you find nothing. You look at, we send 102 different genes, sarcomeric genes, and they all come back normal. Okay, so it's not blamed. Now, it could be epigenetics. We don't test epigenetics, but at least for genotype, the genotyping is normal. But the people have the exact physiology. They're short of breath, they have exercise incapacity, they have a 2-centimeter thick septum, sometimes an 80-millimeter outflow gradient. Those people all get put on mavacamten, and it's a remarkable improvement. Within a week, usually, once you find the right dose, they feel better. Their gradient, we get a gradient below 20 or 10 in all of them, depending on when you find the right dose. And their exercise improves. And if you do biomarkers, we talked about NT-proBNP earlier, their NT-proBNP falls by 75% to 80% in the first week once you find the right dose. Troponin also goes down. So there are lots of good things that come out of that. So that's a biologic disease. We don't put defibrillators in those people. We treat medicinally.
Any other questions on heart failure, cardiomyopathy?
What about the fluid restriction? Do we restrict fluid or not?
So that's so the question was, and I'm going to expand it a little bit, fluid restriction and salt restriction both have been shown to be worthless in heart failure, okay? And we thought that was the case. So I've told this vignette to Mo before, but when I was one of the co-authors of the first guidelines on heart failure, I kid you not, we spent 6 months arguing about what to put in our guideline about fluid and salt. Because all the brochures that were handed out at the hospital and all the nutritionists said sodium restriction, but there were no data to support it at all. They finally did salt restriction and they did water restriction in people. Turned out it was useless, didn't make any difference. So we do not restrict either. Now, if you had some nutcase who was drinking 20 liters of water a day or something, okay. But in terms of the normal amounts, we do not restrict.
I'm glad you brought up that question. It comes up over and over, the sodium restriction, water restriction. Thanks for elaborating on that. Okay, next question. A 49-year-old man with no prior history of cardiovascular disease presents for his routine follow-up visit. Blood pressure is 130 over 92 millimeters of mercury, confirmed on multiple measurements. BMI is 29, non-smoker, no diabetes, normal lipids. His ASCVD 10-year risk is 6%, so borderline. He feels well, not on any medication, and has no symptoms. Which of the following is the most appropriate next step in management? A, initiate a low-dose thiazide or ACE inhibitor. B, recommend lifestyle modification and reassess in 3 to 6 months. C, check TFTs to rule out hypothyroidism. D, order an ambulatory blood pressure monitor.
Can I choose more than one?
You can. You. emphasized multiple. Okay, 50%, in my opinion, got it correct.
Yeah, and the reason I asked if I could choose more than one is I actually agree with the plurality of people here who would choose actually two things. For sure, you should recommend lifestyle. I mean, the guy is I don't know what his belly circumference is as per our talk, but he's clearly overweight, almost certainly. I mean, it doesn't say he's a muscle builder on testosterone and growth hormone and stuff. So I think his BMI probably indicates central adiposity. So lifestyle changes for sure should be recommended. And if accomplished, so if you look at the weight loss data, whether it's weight loss from a GLP-1 receptor agonist or weight loss from gastric bypass surgery or just diet, all of those lead to a lowering of blood pressure. Okay, so for sure his blood pressure, if he succeeds in losing central adiposity, his blood pressure will come down. Now, the second thing though I would strongly consider is the ambulatory blood pressure monitor. And the reason is because if you just rely on, even though it's confirmed on multiple measurements, in-office blood pressure readings are often misleading because 35% of people will have a substantial enough white coat effect that they will be labeled as having hypertension when they do not. And for a 49-year-old who's going to live 40 more years, I don't know I want to really commit somebody to 40 years of potential antihypertensive therapy if they don't have hypertension. So yes, I would recommend, listen, you need to lose 10 pounds or 15 or whatever the amount is. But I would also get a 24-hour ambulatory blood pressure monitor because this guy's blood pressure could be 115/70 at home, and then the blood pressure issue is off the table, and you won't have to consider thiazide ACE inhibitor or any other approach to pharmacology for possible hypertension. Now remember, the 130/92, of course, most of you say, well, that's not very bad, and I would agree with that. But epidemiologically, the sweet spot is 115, and every trial, including one in the recent months, showed that if you drive the blood pressure down to 120, you benefit people. So it's not inconsequential. If his home blood pressure were 130 and he didn't respond to weight loss, would I put him on pharmacologic therapy? I would be tempted to do so.
So my reasoning behind this question was I wanted you to speak on isolated diastolic hypertension. His blood
Yep.
pressure is consistently 92 or above. And would you think about something like hypothyroidism as a
I
cause?
would.
That's why I put that
No,
as a
I
choice.
wouldn't, because I actually don't think isolated diastolic hypertension exists, okay? The reason that term came to be is because we are allowing the systolic pressure to be higher than it otherwise biologically would be, right? So and as I said, the normal blood pressure for a person in their 40s who's not living in an industrialized country would be like 102/70 or something like that, right? So the fact that his blood pressure is 130, he actually has systolic hypertension. It's just that we've become inured to the fact because we think 140 because that's what the number was from 50 years ago, and it turns out it's not true. So if somebody has diastolic, I mean, you'll never see a blood pressure of 120/110. You know, that physiologically is impossible, right? So everybody that has diastolic hypertension also has a rise in their systolic, maybe not to the level that it makes bells go off in our head. And remember that the sickest people have high systolics and low diastolics, right? The pulse pressure difference. That's the biggest marker for cardiovascular risk because those are older people with stiff blood vessels. So I'm not worried about a diastolic of 92. I'm actually more worried about the 130 and the fact that the guy's heavy.
So a couple of questions that brings up, because we know that blood pressure is supposed to drop at night when you're sleeping about 25%, and you have these non-dippers. So what if somebody is on monotherapy, one agent, what time is best time to take his antihypertensive?
It doesn't matter because most of the antihypertensives have long-lasting effects. And this has actually been proven now in clinical trials where they've actually randomized people to nocturnal or morning antihypertensive therapy. Didn't make any difference. But I do want to amplify one thing you said. So the single most predictive blood pressure for cardiovascular events is nocturnal blood pressure, which you can't get in your office and the patient can't measure on their own. It's only measurable with a 24-hour ambulatory blood pressure. So the Spanish are way ahead of us in this arena, and they have really strong data, over 100,000 people in the database, followed for 20 years, and if you just put that in and say, okay, way back when, 20 years ago, what was the predictiveness of the in-office, like this guy, 130/92, versus 24-hour ambulatory blood pressure versus nocturnal blood pressure? And it turned out the average nocturnal blood pressure was 7 times more revealing for cardiovascular events than either the in-office reading or home readings measured by the patient during the day. So if you had to say, what's the most important, it was actually nocturnal blood pressure. Now, some of that may be what Dr. Pelayo was talking about, that who has high nocturnal blood pressures? Well, a lot of them, it's because they have disturbed sleep. But it's a time when you're supposed to be dissociated from the external influences, and that's a time when you'd expect your blood pressure to be low. So I tell people, if your blood pressure is high at night, you have a problem. I don't know if the problem is sleep apnea or the problem is you actually have hypertension, but it's the single biggest risk. And what stuck out was, what was the risk of nocturnal pressure? It was actually stroke. Turned out stroke was most predicted by nocturnal blood pressure readings.
So,
Dr. Frankel.
Wondering how many providers here in the room actually have access to.
So the question is, how many of you have access to 24-hour ambulatory blood pressure monitoring, either in your office or easily available, that you can?
I can see the sign, and it's the only place that I can send my patients to for a 24-hour monitor is Sturgis.
Yeah, so we have multiple, I put them on, I read all of them in our institute, so I do this every day. I've read thousands of them. It's an incredibly powerful tool. And as she was just saying, and she's my wife, so just so you don't know. And we work in the same mother institution, but where her office is, they don't actually have these in her office. We do, but you don't.
let's see this.
Get them when I refer to the mother.
Yeah, that's how shall I say? I mean, I think everybody should have access to them. Does anybody here use them? You should. So let me just tell you, it's not an expensive test. So the hardware costs like $2,000, okay? The Medicare reimbursement rate for it is like $80. And Medicare uniformly pays for it, but only if you put down the code white coat hypertension. They also pay for masked hypertension, which are people that have high blood pressures in the doctor's, in the home, but normal in the office, which is only 10% of the people, but they will pay for that. But if you just put down white coat hypertension, it'll be paid for. And I know this because I've done thousands of them, right? If you put down hypertension or you put down uncontrolled hypertension, refract, it'll be denied 100% of the time because the national coverage determination only allows white coat. So just that's the hint.
Yeah, important because 1/3 of Americans are on antihypertensive agents that they should not be.
Yeah, so and so the study I referred to in Europe, so in the UK right now, they in Scotland, did a study in Scotland. Turned out it was cost effective for society to have 100% of the people have a 24-hour blood pressure when they were considering antihypertensives for what you just said. Because for 35% of the people, they didn't need any blood pressure meds, and therefore you didn't need to buy hydrochlorothiazide or amlodipine, and you didn't need a basic metabolic panel to follow their potassium and their creatinine. So they actually saved money by doing a 24-hour ambulatory blood pressure. And I will tell you, it is so helpful in my day-to-day decision-making about do I up the dose of amlodipine, do I add an ACE inhibitor to ARB, all those types of decisions. If you're not getting a 24-hour blood pressure, you're shooting in the dark.
Now, just as you pointed out, I mean, prior to, I think, a couple of years ago when the study came out that it doesn't make a difference when you're taking your antihypertensive, prior to that, we thought it was better to take it at night.
Yeah.
So I'm still in that mode, but it doesn't really matter what time it's taken.
Yeah, and there were confounders, which is that previous data had said if you tell people to take it at night versus morning, there's more compliance with morning. And the difference was not inconsequential. It was like a 20% difference in compliance because people fell asleep in front of the television set and they forgot to take their nocturnal medicine. And so morning medicines were more likely to be taken. Okay, so there was the countervailing argument that even if biologically there may be a benefit of taking it at night, 20% of the people aren't going to take it at night, so let's give it in the morning.
You
But
had a
they
question?
actually did the study and it didn't make a
Well, I
difference.
was just gonna say, what's your secret? Because I think a lot of providers are reluctant to purchase them because of the non-compliance of the patients returning them. I mean, even Holter monitors are
Yeah, so I mean, obviously it depends on your local. So the question was, my institution made people fill out forms that say, if you don't return it, we will bill you for the cost of the device.
Yeah.
But I will tell you, I mean, just to your point, sometimes she says, what about people who don't return it? And we've had some where we had to like, not send the police, but could you please return the monitor? But I did have a guy put it on, and we said, put it on for a day, don't get it wet, et cetera. And he went surfing. And he dropped it in the ocean, and of course, there went my $2,000 device. And his excuse was, well, I never fall in. And you go, what, so there will be time. And it's what I would call the cost of doing business, right? But we've not had much, in fact, ours usually wear out before they get lost or not returned.
So let me ask you a very practical question, I hope, because patients ask me all the time, providers tell them, and I don't think there's any quite right answer, but I'll tell you what I do. I tell patients, I don't like them to take their blood pressure too many times a day. It creates a problem for me. So I'll usually tell, this is exactly what I tell patients. Especially new patients, I'll say, take the blood pressure in both arms, follow the higher arm. Number 2, I'll tell them the best time to check blood pressure is in the morning because most MIs and strokes happen in the morning. I'll tell them both feet on the ground, try to relax before you have any coffee. If you have coffee, wait about an hour, hour and a half. If it is high, wait 10, 15 minutes, check it again. If it comes down, that's the real blood pressure. Now, some people come in, they're taking it 3 times a day, some twice a day, so how wrong am I, and what should we tell patients?
No, all those things I think are sound advice. The difference between all the things you've heard about, make sure your feet are on the ground as opposed to dangling and stuff, those make a difference of between 2 and 3 millimeters of mercury, which in a big trial is actually significant because a lot of clinical trials, you're talking about a 5-point difference between intervention and no intervention, and 3 millimeters is a big difference. But for my patients, I think that's less of an important thing. There is a code you can bill Medicare for and get reimbursed for somebody taking their home blood pressure, okay? The rule for that is they have to take it twice a day for a week. And so normally that would mean morning. And why morning? It's what you said. It's because morning is the highest blood pressure for most people, right? The circadian difference is that the blood pressure is highest in the morning, and then it gradually goes down. There's a slight dip at evening time, at dinner time, and then, of course, once you go to bed, it plummets, as you said. There's the normal dip, and then it starts rising at about 4 in the morning before you wake up. So that's the normal circadian variation. So if what I tell them is if it's normal repeatedly in the morning, it's going to be fine. Now, the one caveat is that the home blood pressure machines, the technology of it is such that they're not always precise for an individual patient for the measurement. So we encourage them to bring it in, not to calibrate it. That's what people think. The old scales where you could turn a screw and adjust it to get, you can't do that with the home blood pressure machines. But what you can do is to measure it and see what's the tear factor if it reads 5 points higher than your more sophisticated machine in the office, right? And then you can use that difference to say, okay, yours always reads 5 points high, we'll just subtract 5 points. It's a simple thing. Or it can read 5 points low. It can read high, low, it can be all over the map.
There was an audience question back there. Somebody have a question?
So, I work in an urgent care clinic, and a lot of our patients don't have primary care, and they come in and high blood pressure. So if I wanted to do a 24-hour ambulatory blood pressure, would I just refer them to Dr. Khan?
Well, only if Dr. Khan has a 24-hour,
Well,
so.
The question
Yes,
was
Where
that,
are
I
we
don't know
with
where
that?
he has one.
can you just repeat
So
the
you're
question?
just putting her on the spot because we've lost a few patients, destroyed a few, didn't bring. We just talked about purchasing
Yes.
more. So when are they coming? Put her on the spot.
Soon.
In the day, I'll have them there.
That's a
So
great
yes,
answer.
the right answer is refer them for a 24-hour ambulatory.
So the question was, she works in urgent care with patients that sometimes don't have primary cares. How does she refer them
Yeah.
for 24?
Yeah.
One more question.
The Medicaid.
Medicare code for the home blood pressure monitor, you said there was, Medicare pays for that.
Well, let's see, there are 10,000 CP2 codes. No, I don't, I mean, I can get it for you, but there is a specific code for that. And it was, and you know, Mo knows I'm the representative, your representative to Medicare for these payment reasons. And we insisted that there were so many things that we collectively, people in the trenches, do without reimbursement that it's unfair. So one of the things, when you tell somebody in your office, I want you to measure your blood pressure twice, keep a log of it, send it to us, and we'll give you advice. Well, you're offering free advice and doing a service. You need to be recompensed for that. And so they do actually have a code, and it's a separate code that you can bill for literally home blood pressure. And you know, even though a lot of these codes are relatively small amounts, I will tell you when they add up over the year, it's not an inconsequential and it's necessary. We need primary care reimbursement to be fair. You know?
We'll try to get that code for you guys.
Yeah.
All right,
Another question.
next,
There were some questions.
go ahead, please.
Yeah.
What-
So, and as I said, there's actually a code to educate people about things, and then there's a code for reviewing the data that they collect. But, and it has to be at least 2 readings for a week. If they go home and they call you the next day, you can't bill the code. Okay? And what was the number? What was the number for the?
One of them is 99473. That's for when they're receiving education and training on it. And then the other one is 99474, and that's for interpretation.
Yeah, so 99473 is educating people about the blood pressure and how to take it, et cetera. 99474 is when they return the data to you, and they don't have to come in. It can be electronic, it can be faxed, it can be sent by carrier pigeon, doesn't matter.
Okay.
There was a question in the back.
What do you find is the discrepancy in these wrist blood pressure
So the question is the discrepancy between blood pressure machines that are home, yeah. So she'll tell you, so the machines I already told you cost like $2,000, you know, and the home ones cost $50. You tell me how they can make a cuff and sell it for $50 at Walgreens that actually takes a blood pressure. So it turns out it doesn't actually take the person's blood pressure, okay? The home readings, what they have a little chip. It's like, I kid you not, a $1 computer chip that has an algorithm built into the chip. And the cuff automatically inflates with a little pump, and then it deflates. As it starts to deflate, oscillations appear in the cuff when the artery starts pushing the cuff. So you have the cuff doing this, okay? The little computer chip graphs the oscillations and fits the graph to previous people and say, well, this decline normally means a blood pressure of 126/78. That's what the cuff does. And when you look at a scattergram, which I can show you on my computer in the back here, it's unbelievable because if you and I form 2 guys' blood pressure cuff, okay, how would we get it certified? That the mean blood pressure of all the people we put in this study has to be within 5 points of the actual blood pressure. But here's the thought experiment. If every woman in this audience read 20 high and every man read 20 low, the cuff is certifiable because the mean is there. So for any one individual, it can be plus or minus 20 millimeters. And believe me, I'll show you the data because I'm sure your subscription to the hypertension, they actually have an entire journal of high blood pressure machines. It's like, are you kidding me? They have a journal for that? But that's where they publish the data on these. And when you look at these data, you go, are you kidding? I'm relying on those machines to make decisions? So they're not that accurate. Now, I will tell you, in any one person, the direction is usually accurate. Meaning, if they say my home cuff says it's 138, and now my home cuff says 128, probably they've declined 10 points.
My question is actually more simple. The wrist one versus
Arm is always better than wrist. Remember, the blood pressure goes up as you go down the arm, and the oscillations are greater in the arm. So between finger, wrist, and the upper arm, you always want the upper arm. And what Mo said is true. There's a disparity in most of us. Within 10 points, it's usually less than that. You want to use the higher of the 2 arms. You can't fake a higher pressure, so you want to use that as your marker.
Okay, next question. A 62-year-old man comes to you concerned about his blood pressure, which averages 160 over 90 millimeters of mercury. His blood pressure in your office is 162 over 100. He is asymptomatic. Physical examination is unremarkable. Which of the following is the best treatment option? A, send the patient to the ER for treatment. B, initiate amlodipine, 5 milligrams. C, initiate hydrochlorothiazide, 25 milligrams. D, initiate combination of an ACE inhibitor / calcium channel blocker. This patient has stage 2 hypertension. Okay, so I put up this question because I see it all the time. Richard, I want you to comment on the rule of tens and
Yeah, so, from data from randomized trials where placebo-controlled trials, which you can't really do anymore in hypertension because we know we have to treat it. But in the old days, you could take people like this and randomly assign them to placebo for the next 2 years versus a drug versus 2 drugs, et cetera. And what those studies have shown, and these are huge trials, some of them had over 40,000 people in the clinical trials, is that if you just throw a dart at the old PDR and it lands on a drug and you pick it, you're going to get 8 to 10 millimeters of blood pressure reduction on average for any of the approved drugs for hypertension. Okay? And that's a rule of thumb. If you start at 160, you get more reduction than if you start at 139. So it's going to be more than 10 for a guy like this. But what's clear is that if somebody starts at 160, if you believe these numbers, they're not going to get to 130 with any one drug. They're just not. So starting with combination therapy out of the gate for somebody like this is a wise move. And because there are lots of combos that are poly pills already, there are 2 and there are triple combinations. I think it's totally, whether it's an ACE inhibitor, a calcium channel blocker, an ARB and a calcium, I don't care, but I think combination therapy out of the gate is a smart idea. And you'd expect for an appropriate drug combo to get at least a 20-point reduction. So it may be that this gentleman will respond to one pill, and pill burden is important. Now, some of the PBMs are currently mandating that they won't give combos and you have to give 2 separate prescriptions for the same thing that's in one, which I find to be totally stupid. But you will encounter that by some payers. But I think a combo therapy out of the gate is absolutely the right thing.
so again, you're only going to get an average of about 10 millimeters of reduction
Per drug, per ingredient.
Per ingredient.
Yeah.
Does that mean you give max dose out the gate?
So the question is, what dose do you choose out of the gate? I would, there are mitigating factors. So obviously, if the person's creatinine is different or potassium is different, it's going to influence you. But in a person like this who's basically, I would choose a medium dose right out of the gate. So for this type of combination, generally the calcium channel blocker is going to be amlodipine. Usually it's going to be 5 milligrams. And the either ACE or ARB. And the ACE inhibitors, pretty much all the ACE inhibitors are the same with regards to blood pressure reduction. Not quite true with the ARBs because there are ARBs that are better. So if you look at like the least potent ARB would be losartan, right? The most potent would be olmesartan or azilsartan. And head-to-head, and I was an author of one of those trials, it's clearly the case that olmesartan and azilsartan are better than, say, losartan or even medium-dose valsartan. So if I were to choose, what would I do with this guy? I'd put him on a combination of like olmesartan and amlodipine, which is cheap, generic, and they have a 520 or a 540, which is 5 of amlodipine and 20 or 40 of olmesartan, and this may be all the guy needs.
So one of the providers in my office told me that he would be very happy if at the end of this conference that the providers learned only one thing. He would be happy that beta blockers are not first line.
Yeah, that's a very important statement. So I bashed beta blockers a little bit for hypertrophic cardiomyopathy because they are not, and believe me, I know the data, they're not that good for HCM. They're terrific for low ejection fraction heart failure. Best we have. They are not terrific for hypertension, and it's a myth. So the reason they were used early on is because we had no other medicines. I mean, think about it, right? The first antihypertensive was invented in 1956. when they were looking for an antibiotic and they stumbled across thiazide diuretics, and they're still used and they're very useful. Beta blockers came out later as heart rate reducers and just happened to also lower blood pressure. But the older you get, the less antihypertensive effect there is with a beta blocker. So they have been moved down a notch, and beta blockers are not considered first-line therapy any longer for the management of hypertension. Yes, for reduced EF heart rate, yes, for arrhythmias, and maybe migraines and all the other things we use them for, but not for hypertension. You have better choices. ACEs, ARBs, calcium channel blockers, thiazide-type diuretics. I mean, we have a lot of choices, about over 100 actually for hypertension. And one neglected class there are the mineralocorticoid receptor antagonists that we mentioned earlier, spironolactone and eplerenone, which are fabulous for hypertension. Are you guys doing renal artery ablation?
No.
So in our patients who get sent for renal artery ablation for refractory hypertension, I will not allow them to have it unless they've been on spironolactone, because a lot of these people have hyperaldosteronism and even hypercortisolism as the genesis of their high blood pressure, and they respond beautifully to spironolactone. So that's kind of the drug that has been around a long, long time and is underutilized.
And then I have a question. There are some urgent care ER providers, so can you comment a little bit on some of the terms that kind of get thrown around in terms of hypertension, hypertensive emergency, hypertensive urgency?
Almost never. So who would need to be admitted to the hospital with hypertension? I don't think I've seen somebody in 20 years that I would admit. Now, that said, when I gave the hypertension talk here a few years ago, I showed the slide of FDR's blood pressure, right? And the day that Franklin Delano Roosevelt died, if you remember, his blood pressure was 300 over 190. Okay, that's a hypertensive emergency. And he then, of course, had a hemorrhagic stroke and died. So yes, but somebody like 160, would I ever admit them to the hospital? Never, unless they were having an acute stroke, subarachnoid bleed or something like that, or maybe if they were in pulmonary edema. But the truth is that every time you guys go out and exercise, your blood pressure is 210. And you don't admit them to the hospital because the blood pressure is 210 on the treadmill. So I don't, this is almost never an hypertensive urgency emergency. They need attention, but they need to start a medicine.
Yes.
Very often for gestational hypertension and preeclampsia, we use labetalol
Yeah.
over, and nifedipine is another option. But from what you're saying,
So so the question was for gestational hypertension, okay? So first of all, no old ladies are gonna be having gestational hypertension. So by definition, so if you heard what Mo and I were saying, so young people respond better to beta blockers than do older people. So you can still use it in younger people. The only reason labetalol is in there is because it was grandfathered in. There's nothing unique about labetalol. It's just that no pharma company wants to do randomized trials on pregnant women who are hypertensive. Who would be gutsy enough to do that? And so we have this paucity of data, and we're using drugs like hydralazine. Why? Because they were available in the 1960s when the rules were less, and they say, well, it's presumed to be safe because we've been using them for 60 years and therefore use those. Other than drugs that are known to be potentially harmful, the renin-angiotensin drugs, I mean, like, what's the data on amlodipine being harmful in pregnancy? And is labetalol the end-all and be-all? No. It's just been grandfathered in, that's all. But you can still use it in pregnancy.
nifedipine, you think be superior? Or that's our other option?
I almost never give nifedipine anymore. I mean, I think I have some patients on nifedipine and they use it rectally for anal spasm, okay? That's literally why they use it. Don't ask, yeah. But I think nifedipine should be replaced by amlodipine. Amlodipine is a better drug than nifedipine. Nifedipine had its day, but it's too short acting and stuff like that. So if you want to use a calcium channel blocker, I think the non-dihydropyridine calcium channel blockers might be used, but generally, if you're going to use a dihydropyridine, it would be amlodipine.
You don't think nifedipine is more potent than amlodipine?
I do not.
Really?
Yeah. It's just that it's shorter acting, so you get a burst effect. So the half-life of amlodipine is 2 to 3 days. So if you're starting it, you're not going to get a peak effect until you get 5 half-lives, which is longer. That's why there's this. But if you look at actually blood pressure long-term, amlodipine is not inferior to nifedipine for blood pressure.
Yes.
leave it alone, or do you think you can take them off from?
Yeah, so the question was, what if somebody comes to you, they've seen somebody else, they've been on metoprolol for a while, and their blood pressure is reasonable, right? Would I take them off it? No, I think if their blood pressure's, now, you might argue maybe they didn't need it in the first place, maybe they didn't really even have hypertension, but there's some downsides to metoprolol, right? Metoprolol crosses the blood-brain barrier, it can cause depression, and it definitely, if you look at exercise studies, it impedes exercise because of chronotropic incompetence and a bunch of other things. So if all other things were equal, do I think that I would prefer to have somebody on a thiazide or amlodipine or an ARB I would, actually. Now, if somebody's doing perfectly well on metoprolol, might I leave them on it? I think that's your choice. I wouldn't feel strongly about switching them, but I wouldn't choose it preferentially.
And do you have to kind of taper off and just say, no, stop?
So the question is, do you have to taper off beta blockers? So in the days when we had very short-acting beta blockers, this really came out of propranolol and drugs that nobody uses anymore, like Practilol and stuff that are historical items. There was a concept that you would have rebound. But in honesty, like metoprolol succinate and drugs, they're long enough half-life that when you stop them, they self-wean over a period of days, and so you really don't see withdrawal, if you will.
I think we just feel better if they have known coronary artery disease and they've been stented to wean them off.
Yeah, although remember the metoprolol and coronary disease question has been brought. So metoprolol was first used post-infarction in the 1970s, right? And those clinical trials just took everybody who had a heart attack and randomly assigned it to beta blockers. And I did those trials back in Boston. And it showed that people benefited who had coronary disease on beta blockers. But on reflection, it was actually the people that had big heart attacks because nobody those days got a stent, nobody. And so you had a bunch of people with reduced EF heart failure who were put on beta blockers who benefited. If you had somebody with a normal EF who was put on a beta blocker who happened to have coronary disease, they didn't seem to benefit, right, other than arrhythmias and stuff. So it's been called into question in their articles that are both pro and con, but the randomized trials don't seem to indicate that beta blockers in the coronary population have a unique benefit.
Oh, what's going on with the verapamil diltiazem role for blood pressure management? Is that something fading away? Or?
No, so verapamil and diltiazem, the question is what's their role? They're generally considered to be slightly less effective than the dihydropyridines like amlodipine. They have more GI side effects. So in the elderly population, constipation with verapamil, for example, is an issue potentially. There's some data that in niches like hypertrophic cardiomyopathy that maybe verapamil may be useful and other things. But I think most of the time, other than for arrhythmia control, right? So if you're looking at diltiazem, what's the main use that we cardiologists use diltiazem? It's usually for rate control and atrial fibrillation. If you're just going for an antihypertensive, if they happen to have AFib and SVT, diltiazem or verapamil, perfect choice. Verapamil I would avoid in older people, but diltiazem is a good choice. On the other hand, if you're just looking at blood pressure control, we generally prefer amlodipine. With, of course, the noxious side effect being ankle edema when you go to higher doses.
About the people that get lower extremity edema.
Yeah, so if somebody, and as I alluded to a moment ago, so for sure the dihydropyridines, the main side effect is lower extremity edema, and that's a local hydrostatic effect. It's not heart failure, it's not volume overload, it's local basically precapillary arterial dilation, which floods the local tissue and exceeds the lymphatic drainage of the ankles. And when that happens, they either live with it or you have to go to a lower dose. It's more common in women than men. It's very dose dependent. Now, the good news is as you get older, lower doses of amlodipine hang around longer. So if you have an 85-year-old woman, a lot of them, 1.25 of amlodipine is all they need. And when you go to 2.5 or 5, they all get swollen ankles. They don't like it. So those people, I would try a lower dose. They don't make a 1.25, so you have to either split the 2.5 or take it every other day.
No, that's why you're better off with a combination, because the
Yeah.
amlodipine causes afferent vasodilatation, no efferent vasodilatation. That's why you get the edema. So if you use a combination, there's vasodilatation of both the afferent and the efferent vessels, and you get significantly less edema.
Yeah, so the edema is usually not benefited by thiazide diuretic kind of things, but in the randomized trials, as Mo just referred to, if you use combo therapy with an ACE or an ARB and amlodipine, there's less manifest edema on the combo therapy than on monotherapy with amlodipine.
And that comes up a lot because people get ankle edema and then end up adding on thiazides. But
Yeah.
if you look at the mechanism, actually, the edema is less if you add on an ACE or an ARB
Right.
compared to the thiazide.
Okay, next question. Everybody should get this right. What is the most common cause of secondary hypertension in terms of prevalence in the general population? A, hyperaldosteronism, B, renal artery stenosis, 3, obstructive sleep apnea, D, hypothyroidism, and E, drug or alcohol induced. This was covered today. Okay. 80%, 85% obstructive sleep apnea. Rich, let me ask you this question. I rarely search for secondary causes of hypertension. What's your approach?
Yeah, I would agree with that. And so some of them are listed here. I can tell you in Santa Monica, where I practice, I'm not sure that obstructive sleep apnea would be the right answer. And the reason is because about 20% of the hypertensive population have hyperaldosteronism. And it's grossly underdiagnosed. And emerging, and you'll see specific therapies for this in the next year, is hypercortisolism, because both cortisol and aldosterone attack the same receptor. And you know that because when you give spironolactone, how come spironolactone causes breast growth in men and nipple tenderness and stuff? It's because the mineralocorticoid receptor shares the cortisol and estrogen receptors and things, so there's crosstalk between those receptors. So hyperaldosteronism is the one exception, but most of the time we don't look for it. What we do is what I alluded to earlier. You just give spironolactone and the blood pressure goes down. You assume that there was hyperaldosteronism. Now, you will begin to see that there will be a push to measure hypercortisolism in your hypertensive population, especially people who aren't responding well. And that requires you to do an ACTH suppression test, which we used to do looking for, adrenal hyperplasia kind of thing. But it turns out a significant number of people with hypertension also have that. It's just subclinical. And if you measure AM cortisol, you won't pick it up. So I'll just tell you that that's going to be coming in the next year. You will be hearing about that. But right now, I think sleep apnea in the general American population is the correct answer, but close behind it is hyperaldosteronism. I do not look for renal artery stenosis unless there's an outlying, somebody who you put them on an ACE or an ARB and their creatinine goes up or something oddball. But usually you don't have to look for a cause of hypertension.
Now, the choice E, I find a lot of patients in my practice, I find alcohol makes it difficult to control blood pressure.
Why is that? I mean, are they fat?
But you don't think it makes it a little more difficult to control blood pressure?
Well, I think if they're abusing cocaine,
I mean,
it's like,
I had a provider who drinks quite a bit. And I told him to, he didn't believe it. But anyways, he stopped drinking for a few weeks and called me to tell me his blood pressure is normal. So I don't know.
yeah, I don't know either. I mean, there may be somebody in the audience who knows more about that than I do. But.
I have seen a correlation of people who drink when their pressure is high, having that high.
Yeah.
Okay, the next question. A 56-year-old woman comes to your office to follow up her abnormal kidney function and elevated blood pressure. Creatinine was initially found to be elevated on routine lab testing. She has not seen a physician for many years. The patient takes no medication. Blood pressure is 140 over 89 millimeters of mercury and a pulse of 79. Examination is unremarkable, trace bilateral pitting edema. On her lab work, what's significant is the creatinine is 2.7 and GFR is 25. Also, 24-hour urine collection shows 1.5 grams of protein a day. Which of the following is the best initial therapy for the patient? A, amlodipine, B, benazepril, C, carvedilol, D, clothalidone, E, hydralazine. I see this a lot, so that's why I thought this would be something we could discuss. Okay. I'm glad to see 51% said benazepril.
Yeah, I would agree. I mean, my answer to this was this lady needs to see a nephrologist because this person has overt proteinuria, right? So that's a real marker that there's intrinsic kidney pathology here. I mean, we're all going to be expected in the near term to measure albumin to creatinine ratio in the urine because it's an important marker, it turns out, for kidney dysfunction and for heart failure, et cetera. And it's targetable and manageable, and you're going to be seeing a lot about that again. But this isn't albuminuria, this is overt proteinuria. I mean, 1.5 grams of protein. And so there could be other forms of, glomerulonephritis and IgA nephropathy and other things that may need specific treatment. But as an initial go-around, she's hypertensive, she has advanced kidney dysfunction, and she has overt proteinuria. So she needs nephroprotection. And the two agents that are most useful these days are the renin-angiotensin modulators, as listed here with benazepril, and an SGLT2 inhibitor for kidney protection, any of the SGLT2 inhibitors. But she's going to end up, I suspect, getting a kidney biopsy and other imaging stuff.
So in a patient, let's say without the albuminuria, if a patient, I'm comfortable, even if the creatinine is 3.3. I'm comfortable with an ACE or an ARB. But I see a lot of providers discontinuing the ACE or ARB. You want to comment on that?
I mean, if somebody's creatinine went from 0.8 to 2.7, then yes, then you have to reassess and look at for renal artery stenosis, for example. But no, I have no compunction so long as the potassium is okay for putting somebody on an ACE inhibitor and ARB even with a creatinine clearance of 25. And for the SGLT2 inhibitor data, even if the estimated GFR or measured GFR is very low, 20, 15, 10, they still have nephroprotection with an SGLT2 inhibitor. And probably this person would end up on both. If you do start benazepril or any other ACE or ARB, make sure you check the creatinine and the potassium again. You just can't send them out the door on that and forget about it. Because some of them might have, in fact, renal artery stenosis. It wouldn't cause this degree of proteinuria, but you just want to make sure that the creatinine does. If it goes, when we did the original ACE inhibitor and ARB trials, we were allowed to have the creatinine rise 40% and not discontinue the drug. Right? So if this went from 2.7 to 3.0, would I stop no, I wouldn't stop the ACE inhibitor at all. Now, on the other hand, if the potassium went from 4.5 to 5.9, that's a different story.
So you'd expect a slight, probably 25% increase.
Yeah, maybe a little less. Typically, it would go up 0.2 or 0.3, something like that, right? And that's totally okay. And rather counterintuitively, if the creatinine goes up a little bit, that marks somebody for greater benefit over the coming years, because the creatinine doesn't go up because you're harming the kidneys, you're just adjusting blood flow within the glomerulus. And that marks people. It's like the heart failure data. I see a lot of people where they get put on, I'll just choose Entresto, for example, and their blood pressure falls and they're taken off the Entresto. Well, it turns out if your blood pressure falls on Entresto, you have the greatest benefit of Entresto. So long as you're not passing out, that marks you for actually having a better benefit.
How long should you wait after initiating ASAR before seeing that, or checking the lab?
So when do you recheck labs is the question, and I think it depends how nervous you are. I mean, for somebody that has normal basic metabolic panel, I mean, you can check it a month later. For somebody like this, I would actually check it in a week, because by that time you've reached steady state of the ACE inhibitor, and you're going to probably know whether there's an unacceptable, which there likely will not be. In somebody like this, there's probably a 5% chance that the creatinine, that the potassium will be too high, and you're going to be nervous and stop it and reassess. But I would do, in this particular patient with a creatinine of 2.7, I would do it within a week or two.
Any other?
If the potassium is high? Yeah. So remember that virtually any, and if somebody is hypertensive, virtually any antihypertensive drug will help protect the kidneys, right? So the ones that are neutral for potassium would be amlodipine, for example, which has no discernible effect in terms of handling of this. The thiazides typically would be okay in that scenario, with the caveat that hyponatremia may occur. But most of the other drugs, certainly the ACE inhibitors, the ARBs, even the beta blockers can raise potassium in that situation. So a calcium channel blocker would be a good choice. If you're tempted to use spironolactone, you would almost certainly need to use a potassium binding agent to help if the potassium goes up, which it has a significant likelihood of doing. So I would say amlodipine would be the answer in that scenario.
How about the nephrologist? I see used for hydrolysis in this situation more than.
Yeah, so the question is what I would consider sort of third-tier medicines. So the direct vasodilators are effective antihypertensives without causing electrolyte disturbances. That's true, right? So the ones that would rise to that level would be hydralazine and minoxidil, right? So minoxidil, the downside of hair growth, maybe that's an upside for some of us, but downside usually. And hydralazine, and of course the problem with hydralazine is it doesn't last very long. So it's a multi-time per day drug, and compliance is a major issue with that. But they use it because it is, like amlodipine, doesn't have a potassium raising effect.
Do you use clonidine in your practice?
Do I use clonidine? Rarely. And the reason for that is, and I don't even remember if these data are public, but we used, so remember how clonidine works, right? It's a terrific way to reduce sympathetic tone, but it works in the brain. So it's a centrally acting agonist that reduces sympathetic tone and hence lowers blood pressure and does a lot of other things too. So we participated in a trial of son of clonidine. It was called moxonidine. And what was the benefit of it? Lasted longer, was greater, but when we did the randomized trial, it killed people. The mortality rate was higher, which is why the study didn't make it into the New England Journal of Medicine, right? But it gave me pause about centrally acting alpha agonists like clonidine because the drug that was better than that actually had a higher death rate than placebo. So I don't like, and then of course there's the withdrawal where when you, if somebody's on clonidine and they take it off, there is a rebound with that drug for sure. So to me, clonidine is a fourth tier hypertension drug.
I think if you don't like your patient, you can give them clonidine.
Yeah,
because
give them lots of
they're not going to
clonidine.
feel good. They're going to feel lousy. All right, next question. A 32-year-old man comes for a routine preventative visit. He injured his back at the gym for which he takes naproxen as needed. He has a 15-pack year smoking history. His father was diagnosed with prostate cancer at age 66, and his mother had an MI at age 59. Vitals and physicals unremarkable. The patient is interested in improving his health and asks if he should be screened for any other diseases. Which of the following is the most appropriate screening test? All right, we won't spend much time. Most of you, it's a cardiology conference. Lipids the only answer that makes sense. But I bring it up because I see patients in their 40s all the time, Rich. They've not yet had a lipid panel.
Or maybe they don't remember it. I mean, I do think it's part of, once you achieve adulthood, I think everybody should know what their cholesterol, if you want to use that term, is. This person has a family history of coronary disease, so there's a little more yield in this particular person than in the general population, but he's clearly too young for a PSA. In a non-obese person, hemoglobin A1C is not that useful. There will be other biomarkers that may turn out to be useful even in a healthy guy like this, but right now I think that the standard measurements of lipids are the correct answer.
No, really, it should be checked at the age of 20. We don't necessarily have to treat it, but it should be checked.
And do you check all your do all your lipid panels, do you always add on ApoB and LP little a?
Yeah, so, sort of. So as you've heard me before, so I'm a believer in LDL particle number rather than ApoB. They purportedly measure the same thing, but ApoB is an immunoassay, which is a little less reproducible. LDL particle number by NMR is a physical chemical test that is much more accurate for the in-test variability, and it's way more accurate than an LDL cholesterol it's twice as predictive for cardiovascular risk. Now, you mentioned lipoprotein little a. I think everybody should have a measurement of that at some point, especially if they have a family history like this guy, because it is one of the hidden risk factors, particularly in people with early onset and particularly certain ethnic groups where LP little a. Right now, of course, we don't have a specific therapy for LP little a. The first of the big randomized outcomes trials will come to fruition in the next month. So we will have LP little a data this year, asking the question, and these are people with very high LP little a levels. To get into that clinical trial, you had to have an LP little a level of greater than 200 nanomoles per liter. But it turns out in your practice, that's about 15% of people that have coronary stents, for example, or MIs. So it's a bigger number than you may have thought. And we know that these are all RNA therapeutics that are coming out for LP little a. The only drug currently that lowers LP little a are the PCSK9 drugs, right? So inclisiran and the PCSK9 monoclonal antibodies both lower it by 25-30%, but we don't know whether that's useful. The RNA therapies lower LP little a by 90%. And so those studies, there are 3 of them, over 30,000 patients, and those will all finish in the next 12 months. So we'll have more data about that. Now, do you need to, you asked each time, if somebody has a totally normal lipoprotein little a, it is not recommended that we remeasure it because it's genetically determined. However, if they have a high LP little a, the most recent evidence from last 6 months, there's more variation than we had originally thought. So if somebody has a very high LP little a, we are remeasuring it. But not if their LP little a is 10 or 15, like a lot of people in this audience would have.
And then another comment in terms of your lipid panels, do you tell the patients fasting or do you tell them just draw their lipid?
It's actually, the fasting was a reflection of what I call high school chemistry. And that's that they couldn't discern whether chylomicrons that are transporting your breakfast to the liver versus the LDL particles, which is really what we're interested in, because chylomicrons don't participate in atherosclerosis, but the LDL particles do. But it turns out that with modern methodology, you don't need to fast for a lipid. And in fact, you learn more from a non-fasting. Just like the artifice of having somebody fast for 14 hours and have their glucose measured isn't where we live. So a glucose level that's just random is actually more informative than a fasting glucose level. And that's true of lipids as well.
What about a high HDL?
Next question. Let's go to the next question.
Yes. Question number 11, she preceded, yes.
A 56-year-old woman with a history of hypertension and tobacco use comes to discuss her lipid panel. LDL cholesterol is 160. HDL cholesterol is 105. Total cholesterol HDL ratio 2.6. She was told that because her LDL cholesterol is high,
HDL.
HDL cholesterol is high and the total cholesterol HDL ratio is low, she does not require statin therapy. She's requesting your opinion and willing to start if needed. You recommend A, you agree she does not require statin therapy. B, you disagree and recommend starting therapy. C, you would like additional history, family history, diabetes, etc. D, you recommend a coronary artery calcium score. Okay, pretty good, right?
Again, there's absolutely nothing wrong in a 56-year-old with getting a coronary calcium score because you can de-risk somebody, right? So this same person, if they had a coronary calcium score of 0, your answer might be different than if the coronary calcium score were 345 or something, right? So I don't think anybody who answered that is wrong. And of course, it's always useful to get additional history. I mean, if both parents died of an MI at age 59, that's going to influence your choice of therapies. But as per the question a moment ago, so if you look just at her numbers, right? So her LDL cholesterol is high enough that you would be potentially tempted to use primary prevention therapy just because that LDL is high enough. In no way does the HDL influence that LDL risk. No way. In fact, if you look at the HDL literature more closely, having a high HDL is actually a negative. It's a bad thing. You want, and this is true, think about most of biology. You don't want too high of a sodium or too low of a sodium or too high glucose, too low glucose. You want to be in the normal range. So if you look at HDL cholesterol, the sweet spot, even for women who tend to have higher HDLs than men, the sweet spot's between 45 and 50 milligrams per deciliter. And if you're higher than that, the risk goes up. And at 105, like this woman, the risk is twice as high as somebody whose HDL is 50. So this concept that somehow HDL is protective is ludicrous. Okay? And the reason that we got led down this garden path thinking that HDL is helpful and it protects is because the people that had low HDLs tended to be diabetics, metabolic syndrome, and that's what drove the bus. It wasn't that HDL itself was participating. It's that it was a marker for other diseases, insulin resistance, et cetera. So this lady's lipid profile is not advantageous. So do I think it's wrong to start a statin? No. I do agree, though, that getting more history in a coronary calcium will make your argument more solid. But in no way is the HDL protective. In fact, why is it that an HDL 100 is worse than an HDL of 50? So one way you could spin this, and this is what we currently think, so HDL has multiple roles, right? Separate particle, multiple roles. One of the roles is to remove cholesterol from the periphery and bring it back, presenting it back to the liver. So reverse cholesterol transport, maybe bringing it from plaque back to the liver. So think about it. If your HDL is chock full of cholesterol, what does that mean? It means it's not dumping its cholesterol into the liver. So it's picking up cholesterol from plaque, but it's not doing its job. It's just circulating, carrying that. So a high HDL cholesterol is a marker of impaired HDL function. So if you have impaired HDL function and there's some benefit of an HDL particle, then you are marked. And this lady, just from these two numbers, is probably 4 times more likely than her peers to have a cardiac event. So don't be deluded. That's why the HDL, the triglyceride, or the TC, total cholesterol HDL ratio, is not helpful in this situation.
I think we'll have time for one more question. A 60-year-old man, status post MI with stent placement to the right coronary artery, presents for his follow-up visit. LDL cholesterol is 90 milligrams per deciliter on rosuvastatin 20 milligrams. Which of the following is most appropriate for this patient? A, increase rosuvastatin to 40 milligrams. B, niacin. C, Zetia. D, fish oil. Okay, 82% increase says increase rosuvastatin.
Yeah, it's not going to be enough. So might you be tempted to increase rosuvastatin to 40 milligrams? Sure. But remember, when you go from 20 to 40 of rosuvastatin, the additional LDL reduction is in the range of 5%. So he starts at 90. You're going to get him down to 85 with going from 20 to 40 of rosuvastatin. And that is not going to be sufficient. Somebody with a stent, and he's a young guy with a stent, his LDL needs to be below 55. Is there any way, shape, or form you're going to go from 90 to 55 with going from 20 to 40? No, you're just not going to get there. So the right answer is to add a second agent. Now, you could do that in concert with increasing the rosuvastatin to 40 because you're getting an extra 5%. But by itself, increasing rosuvastatin to 40 is not going to be sufficient. So of the remaining answers, niacin has been largely discarded because the niacin trials just did not bear fruit. Traditional fish oil, no, although you heard earlier that the Vascepa preparation, the diethyl esters,
did have a benefit, took longer, so the right answer here is ezetimibe. Now, remember that ezetimibe, 10 milligrams, is the same dose for everybody, only lowers the LDL traditionally by 20 additional %. So you could argue, even if you increased rosuvastatin to 40 and you added ezetimibe 10, you're probably going to go down an extra 25%, and is that going to get you below 55? No, most likely not. But it's worth it because you're going to know that in a month, right? So just increase rosuvastatin, add ezetimibe, get another panel in a month. And if it's not a goal, then you have to add something else. And the other thing would be an injectable. So that'd be one of the two antibodies, right? Either Repatha or Praluent, or inclisiran, which is the RNA therapeutic that's every 6 months that also lowers the LDL by an additional 50%. So can you get this guy to goal? For sure. But I would be happily surprised if he lowered it with rosuvastatin plus ezetimibe. It's worth a shot, but don't think that it's going to get you there in the majority of people, because it won't.
Any other questions, anybody? Well, Dr. Wright, thank you for your time. Appreciate
My
your time.
pleasure, Mo. Thanks for
Thank
having
you.
me.